بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This lecture is about inborn error of metabolism due to defect in carbohydrate metabolism. The lecture will be presented by Dali Ibrahim Wakalla, Assistant Professor of Clinical Chemistry. The carbohydrate defect is categorized into either hemolytic anemia caused by deficiency of enzymes such as hexokinase, pyruvate kinase, glucose 6-phosphate dehydrogenase, or pyruvate dehydrogenase deficiency, carbohydrate intolerance disorder. These include lactose intolerance and fructose intolerance. Also, we have Fructoseuria, Galactosemia, Intolerance, and finally Glycogen, storage disease, and mucopolysaccharides. Number 1, hemolytic anemia caused by different enzyme deficiency. We have hexokinase deficiency, the first enzyme involved in the anemia due to enzyme deficiency. This is a very rare among all the hemolytic disorder. Glycolysis in RBCs is linked with 2,3 BBG production essential for oxygen transport. In the deficiency of hexokinase, the synthesis and concentration of 2,3 BBG are low in RBC, so oxygen unload to the tissue decrease condition lead to hemolysis. Pyruvate kinase deficiency, it is an autosomal recessive disorder and most common red cell enzymopathies after glucose 6-phosphate dehydrogenase deficiency. Pyruvate kinase catalyzes conversion of phosphophényl pyruvate to pyruvate with the generation of ATP. Inadequate ATP generation lead to premature red blood cell death, which is known as Brickell cell. On the other hand, in the patient with pyruvate kinase deficiency, the level of 2,3 BBG in RBCs is high, resulting in low oxygen affinity of hemoglobin observed. Here we can see the blood film in the patient with pyruvate kinase deficiency. The characteristic Brickell cell can be seen. Number 3, glucose 6-phosphate dehydrogenase deficiency. Glucose 6-phosphate dehydrogenase deficiency is X-linked recessive disorder. Frequency is 1 in 5,000 pairs. The deficiency occurs in all cells of affected individual, but is more severe in RBCs. RBCs depend only on hexose monophosphate shunt for their NADPH requirement. Glucose 6-phosphate deficiency lead to impaired NADPH production, so oxidized glutathione is not converted to reduced form. Low NADPH concentration also result in the accumulation of hemoglobin and peroxidase in RBCs, cause loss of RBCs membrane integrity. Till now, it is mostly asymptomatic. But once the enzyme deficient subject exposed to severe infection, administering oxidant drugs such as anti-malaria, such as brimaquine, antibiotics, the sulfamexazole, actylenide, antibiotic, fafism, ingestion of fafabine lead to hemolytic anemia. So in the case في حالات الجلوكوز 6-phosphate dehydrogenase دائما المريض بيكون asymptomatic، لكن الأعراض بتظهر إذا حصل إنه البيشن ده كان عنده severe infection أو تناول أحد الأدوية الممكن تأثر في العملية بتاعة الهيموليسيس، زي استخدامه لعلاجات الملاريا، مثال البريماكوين، مضادات الحيوية، ومسكنات الحرارة، أو تناول البغوليات أو ما يعرف بالفافيزين. تناولهم بيؤدي للهيموليتيك أنيميا. Pyruvate dehydrogenase deficiency frequency is 1 in 2 to in 1 is 1 in 250,000 bears. Main symptoms is lactic acidosis, neurological loss in brain, muscular hypotonia. Number 3, carbohydrate intolerance disorder. These include hereditary fructose intolerance. Here, fructose is accumulated, is an autosomal recessive disorder. Incidence is 1 in 20,000. 1 in 70 persons are carriers of abnormal gene. The defect is aldose beta fructose 1-phosphate aldolase. Fructose 1-phosphate cannot be metabolized. Normally, fructose 1-phosphate is converted to glyceraldehyde plus dihydroxyacetone phosphate. So when there is defect in this enzyme, fructose 1-phosphate cannot be metabolized. It is lead to accumulation of fructose 1-phosphate. The symptoms include severe hypoglycemia, vomiting, hepatic failure, and jaundice. Fructose 1-phosphate allosterically inhibit liver phosphorylase and block glycogenolysis, leading to hypoglycemia. So, الفركتوز 1-phosphate بيؤدي للانهبيشن of liver phosphorylase and block glycogenolysis، بالتالي ما هيحصل تكسير للجلايكوجين، وده بيظهر في صورة hypoglycemia. The treatment: early detection and intake of diet free from fructose and sucrose, and advised to overcome fructose intolerance. Essential fructoseuria due to deficiency of fructose kinase. Fructose is not converted to fructose 1-phosphate. This is an asymptomatic condition with excretion of fructose in urine. Galactosemia, it is a series of autosomal recessive disorder resulting from deficiency of galactose 1-phosphate uridyl transferase, lead to accumulation of galactose 1-phosphate in liver and become toxic. Incidence is 1 in 35,000 bears. So normally galactose 1-phosphate is converted to uridyl phosphate galactose. Here the deficiency of enzyme lead to accumulation of galactose 1-phosphate. Symptoms include the buildup of galactose and the other chemical can cause serious health problems like swelling and inflamed liver, kidney failure, sustained physical and mental growth, and cataract in eye. If the condition is not treated, there is a 70% chance that the child could die. Treatment: galactose-free diet is preferred. Milk will be avoided. So what happened in galactosemia? If the galactosemic infant is given milk, unmetabolized milk sugar build up and damage the liver, eye, kidney and brain. يبقى اللي بيحصل شنو في حالة الجلاكتوزيميا؟ إذا يتناول الطفل اللي بيعاني من الجلاكتوزيميا الميلك، اللي بيحصل إنه بيحصل له brain damage, cataract, jaundice, enlargement of liver and kidney. So the sugar build up and damage this organ. Essential Bentosuria. It is a rare autosomal recessive disorder and benign condition, asymptomatic. Individual does not show any ill effect. Incidence is 1 in 2,000 pairs, primary in Jewish population. The defect is deficiency or lack of xylitol dehydrogenase lead to excretion of larger amount of xylose in urine. Xylose normally must be converted to xylitol, so the deficiency of enzyme lead to accumulation of xylose. It is also reported after administration of sugars such as aminopurine and antipurine. Glycogen storage disease. The metabolic defect concerned with the glycogen synthesis and degradation and collectively called glycogen storage disease. بمعنى أي مرض أو مجموعة بتاعت أمراض متعلقة بتصنيع أو تكسير الجلايكوجين collectively مع بعض بنطلق عليها glycogen storage disease. All glycogen storage disease are autosomal recessive disorder except type 8. Incidence estimated to be between 1 in 1 lakh to 1 million births per year in all ethnic group. Here we can show the disorder and the feature. Type 1 glycogen storage disease is known as Van Jurek disease. The feature is hypoglycemia, hepatomegaly, cirrhosis, ketosis, and hyperuricemia. Type 2 generalized glycogen deposit, lysosomal storage disease. Type 3 hepatomegaly and cirrhosis. Type 4 also hepatomegaly and cirrhosis. Type 5 exercise intolerance. Type 6 hepatomegaly and hyperuricemia. Type 7 has no specific feature. Type 8 is an X-linked recessive disorder. Frequency is 1 in 125,000 pairs. Enzyme deficiency is phosphorylase kinase. Clinical feature include hepatomegaly and fibrosis in children. These symptoms improve with age and usually disappear after puberty. Fasting hypoglycemia 40 to 50 mg per deciliter. Hyperlipidemia, growth retardation, growth often normalized by adult as well. Elevated serum transaminases level, aspartate aminotransferase and alanine aminotransferase more than 500 units per mil. Here in this table we can see the disorder, the enzyme defect or the enzyme involved or enzyme deficiency and the affect tissue. Type 1, the enzyme defect is glucose 6-phosphatase. The affected tissue is liver, kidney and intestine. Type 2, lysosomal alpha 1 glycosidase, all organ. Type 3, amylo alpha 1,6 glycosidase, deep branching enzyme, liver, muscles, heart and leukocyte. Type 4, glycosyl 4,6 transferase, most tissue. Type 5, muscle glycogen phosphorylase, skeletal muscle. Type 6, liver glycogen phosphorylase, liver. Type 7, phosphofructokinase. This is affect the skeletal muscle and erythrocyte. Number 8, the mucopolysaccharidosis. Here we have type 1, which is known as Hurler syndrome. Type 2, Hunter. Type 3, Sanflops. Type 4, type 5, type 6 and type 7. All these are known as mucopolysaccharidases. or mucopolysaccharidosis. All mucopolysaccharidosis show skeletal deformity, corneal clouding, and corneal opacity, mental retardation except type 5 and type 6, urinary excretion of respective mucopolysaccharide, uh, example carnitine sulfate, dermatase sulfate, heparan sulfate, and cartian sulfate. All these metabolized or mucopolysaccharides are observed in the urine sample because the excretion of them are increased. That is all about inborn error of metabolism due to defect in carbohydrate metabolism. Thank you for good listening.